Welcome to my YouTube channel. Today we are going to talk about molecular profiling of endometrial cancers using NGS, implications for multi-classifiers. This presentation focuses on endometrial tumors exhibiting overlapping molecular features, a phenomenon that complicates both prognostication and treatment planning. So these mixed profile cases underscore the limitations of current classification frameworks and emphasize the need for integrative approaches to guide clinical decision making. Endometrial cancer classification has evolved from basic anatomical and histological assessments to integrated molecular subtyping and risk stratification. Modern approaches now combine phygostaging with genomic profiling to guide personalized treatment strategies. The growing adoption of molecular and genomic characterization is changing the current landscape of treatment of these patients. In 2013, the Cancer Genome Atlas Endometrial Collaborative Project proposed 4 different prognostic subtypes based on the integrated genomic, transcriptomic, and proteomic data that reflected endometrial cancer tumor biology. So the 4 subgroups are Pol E ultramutated, MSI hypermutated group, copy number low group, copy number high group. Subsequently, a clinically applicable molecular classification system based on IHC was developed to bridge the gap between the research and clinical practice. This is called PROMISE algorithm. So here the initial assessment begins with the presence of MMR proteins, protein expression by IHC. This is to identify women enabling rapid referral to hereditary cancer program, possibly directing surgical and therapeutic decisions. And the tumors are next assessed for Pol E exonucleus domain mutations, and finally for P53 IHC. So to assign molecular subtypes, all molecular components must be available. That is Pol E mutation status, MMR protein status, and P53 expression status, at least by IHC. But unfortunately, these are assessed at different stages of the disease and at different centers, resulting in delays in proper classification and management in these patients. Recent NCCN guidelines suggest that the decision to use the molecular testing or classification should be based on the availability of resources and multidisciplinary team at each center. As per the recent NCCN guidelines, one has to start with poly sequencing. If a polypathogenic mutation is found, classify as poly subtype. If no poly mutation found, proceed to MMR IHC or MSI testing. If it is aberrant, classify it as DMMR or MSI high subtype. If it is normal, move on to P53 IHC. If there is aberrant or mutant pattern, classify this tumor as P53 aberrant subtype of endometrial cancer. If there is normal or wild type pattern, classify the endometrial cancer as no specific molecular profile subtype, that is NSFP. The recent triple European guidelines includes anatomical staging and tumor characteristics, including molecular classification to risk stratify these patients. So the main change in this 2025 updates is that under NSMP category, they have included ER receptor status. So if it is ER positive and low grade, mostly it falls under low risk to intermediate risk based on your anatomical staging. But if it is ER negative or high grade, it falls into high risk category. I'll show you further slides on this. So how do they define risk groups as per triple European guidelines? The prognostic risk in the respective groups are defined as an estimated overall 5-year risk of recurrence. Low risk group patients have risk less than 8%, whereas high risk group patients tend to have more than 25% of risk. I want to show some interesting cases to just focus on multi-classifier endometrial cancers. So this is a case one, a 59 female with known history of hypertension, diabetes on treatment, suddenly presented with postmenopausal bleeding. On endometrial curettings, the tumor was confirmed as endometrioid adenocarcinoma NOS. Subsequently, she has to undergo radical hysterectomy with bilateral salpingo-oophorectomy, which again showed a low-grade, low-stage tumor with no myometrial invasion, no lymphovascular space invasion, and lymph nodes were uninvolved. And IHC was not done for this patient. The sample was sent for NGS. As you can see, all the relevant genes in endometrial cancers were detected, including POLE mutation and TP53 mutation. Both were pathogenic calls. All of them are pathogenic calls. So, presence of more than one molecular classifier in this case can be designated as multi-classifier endometrial cancer. To be specific, it is called dual classifier endometrial cancer, polymutant and P53 abnormal. Flowchart shows you the distribution of TP53 mutation across the 4 molecular subtypes proposed by TCGA. This stark difference makes TP53 mutation status crucial for distinguishing single from multi-classifier endometrial cancers, which can guide the prognosis and treatment. This heat map shows hierarchical clustering of polymutant P53 abnormal endometrial cancers, single classifier polymutant endometrial cancer, whereas P53 abnormal endometrial cancers are placed very differently. That means they are not clustered with polymutant endometrial cancers, which are represented in blue, and polymutant P53 endometrial cancers, the dual classifiers, which are reflected in pink color here. If you look at the recurrence-free survival in these patients, polymutant P53 abnormal dual classifiers are doing far better than single classifier P53 abnormal endometrial cancers. So the concomitant TP53 mutation in poly or MMR deficient endometrial cancers has been shown to be a passenger mutation that does not affect biological behavior of the tumor. So it has been elucidated that these tumors do not have such poor prognosis as single classifier P53 abnormal subtype. And thus, intensive treatment is not required in such cases. So this patient was considered as polymutant subtype and was kept under observation without any adjuvant therapy given, and on follow-up the patient is absolutely well. Moving on to next case. This is a case of 54 female. We don't have much history about this patient. Patient has got HB report, status post total abdominal hysterectomy with bilateral salpingo-oophorectomy. Again, this was a low-grade tumor with no myometrial invasion. We have got the request for MSI testing by PCR and also for NGS. So this tumor appears to be microsatellite stable by PCR, and there were no other IHC reports available with the patient. We have proceeded with NGS testing. So as you can see, again, multiple oncogenic and likely oncogenic calls in all the relevant genes well documented in literature, including the poly hotspot mutation and MLH1 mutation. So again, presence of more than one molecular classifier it should be designated as multi-classifier endometrial cancer or dual classifier endometrial cancer, polymutant MMRD type. So here the patient was, the tumor was microsatellite stable on PCR, but there was a mutation picked up by NGS. So one has to remember the pros and cons of each assays, technical sensitivity, limitations, etc. Moving on to case 3, this is a 56 female. Again, there is no much history about this patient. Patient has got HPE report and FFP blocks with her. So it's a well differentiated endometrial adenocarcinoma, low grade, but there was myometrial invasion more than 50%. Lymph nodes were uninvolved. No lymphovascular space invasion was seen. So on IHC, there was loss of nuclear expression of PMS2. So they suggested high probability of Lynch syndrome on IHC report. We have further proceeded with NGS. Again, the relevant mutations in endometrial cancer, including POLE and MLH1, along with that PMS2, subclonal mutation was found. So this was again a dual classifier, polymutant MMRD subtype. Not only TP53, the presence of MMRD, the presence of pathogenic polymutation in MMRD subgroup also found to have good prognosis like that of single classifier polymutated endometrial cancers. So it is recommended to classify these tumors as single classifier polymutated endometrial cancers. Coming to our last case, 48 female occasional tobacco chewer with history of hypertension, hypothyroidism. She was a known case of papillary thyroid carcinoma also. So she presented with postmenopausal bleeding and on endometrial curettings, it was confirmed endometrioid adenocarcinoma. Again, low grade. So she has to undergo total hysterectomy with bilateral sarcophorectomy, which showed that myometrial invasion was there and lower uterine segment involvement was present in this patient. So she has got an IFC report with her which showed TP53 wild type expression. We have further proceeded with NGS testing. So you can see that all the relevant endometrial cancer genes are mutated along with poly hotspot mutation, TP53 truncating mutation, and MSH2 splice site variant. So on IHC, there was wild type expression, but we could pick up TP53 loss of function mutation with a good VAF. So there are 3 molecular features in the single neoplasm. So this is triple classifier endometrial cancer with poly mutation, MMRD, and P53 abnormality. So IHC exhibits a high inter-observer variability. Studies have shown the concordance between NGS and IHC for P53 usually ranges from 60 to 90%. This discordance was higher in multi-classifier endometrial cancers when compared to single classifier endometrial cancers. So normally, if you see the wild type expression which they described in the report, looks something like this. Some variable patchy nuclear expression. Whereas the positive, typical positive staining should appear like this. Strong nuclear positivity with some weak staining here. This serves as internal control. There are various patterns of abnormal expression of TP53. I'm not going into that. But I just want to show you that there is something called nuclear blush, which is like very faint, diffuse and patchy light nuclear staining when compared to the wild type pattern. That is neither strong nor uniform. This staining is much weaker than the wild type nuclear expression, lacking the heterogeneous but distinct moderate to strong nuclear signal of the wild type TP53. So if you ideally in this case because of the loss of function mutation in TP53, there should be complete absence of TP53 staining. But unfortunately, in this case, some artifactual nuclear blush is seen, which in this case is mistaken for a weak wild type pattern. That's why it was reported as wild type pattern. This could be the probable explanation in this case, the discrepancy between IHC and TP53. So one has to remember the interobserver variability and such kind of non-specific staining with the TP53 IHC. When you look at the KM curve for overall survival and recurrent-free survival, for poly, single classifiers, multi-classifiers, there is no significant difference in multi-classifiers and single classifiers. You can see that that is falling in the same line. Here, the blue color, like the blue color represents single classifier, and the other green color represents multi-classifier. So there is no significant difference in the overall survival and also recurrent free survival. It is almost falling into one category. So it is very crucial to identify multi-classifiers, not to overtreat or undertreat these patients. If you only take into consideration conventional techniques like IHC, you may underrepresent these cases, potentially leading to inappropriate treatment decisions and misassignment of the molecular subgroups. This Venn diagram represents a proposed approach to therapy decision making in multi-classifiers. So, information on the simultaneous occurrence of polymutant and DMMR classifiers is very scarce and should be considered cautiously. That's why they mentioned that the tumor harbors polymutant mutation and DMMR. They should be cautiously considered as polymutant subtype and treated as polymutant subtypes due to sparse literature available for this category. Whereas if the tumor has polymutation and P53 abnormal subgroup, abnormality on IHC or NGS, it should be considered as polymutant subtypes. If the tumor harbors mutations in MMR genes and P53 abnormality, they should be considered as DMMR subtypes and treated accordingly. If the tumor harbors all the three abnormalities, it should be cautiously considered under polymutant subtypes. So, multi-classifier endometrial cancers are characterized by good prognosis because polymutation is taking precedence over the other classifiers, even in the presence of MMRD or P53. But one has to remember that there are only 11 variants, and some papers say 12 variants, which are like well documented as pathogenic and likely pathogenic variants in poly. So if you see any other variant other than these pathogenic variants, so you should be very cautious in subclassifying the tumor as polymutant endometrial cancer, because there is no literature available about the novel and VUS variants, like how to take them further. So the bottom line is de-escalation of adjuvant treatment should be recommended in these patients, particularly when it is a low stage tumor, stage 1 and 2 tumor, involving any of these 11 exonuclease domain mutations, even in patients with other clinico-pathological risk factors, that is presence of myometrial invasion and lymphovascular space invasion, etc. Tumor mutational burden and the consequent increased infiltration of immune cells due to overexpression of different neoantigens are probably responsible for the excellent prognosis which is associated with polymutational status in these patients. So I was just curious to see our cases and their TMB status. So for case 1, I could not get the tissue. Tissue was scanty, so I could not proceed with TMB. For other cases, you can see that the TMB is quite high. The reported, on an average, the reported TMB should be around or more than 100 mutations per megabase. Our cases were more than 100 mutations per megabase, so it was very well correlating with the ultra mutated poly subgroup. So these images are from the triple European guidelines, which were recently published in Lancet Oncology. So if you see that the low stage tumor, stage 1 and stage 2, if you find poly mutation, it carries low risk. The green color represents low risk. So the green color represents low risk for stage 1 and stage 2. If you find poly mutation in stage 3 and beyond, the prognostic significance is uncertain as of now. The author says that the literature about polymutation and the advanced staging of the cancer is not available widely, so they keep this under uncertain category. The risk is uncertain as of now. You cannot call it low risk, or you cannot put them under high risk category. So what is the role and implications of NGS in these patients? So NGS helps in accurate molecular subtyping as to polymutated subtype MMRD, RP53 or NSMP, and it can detect co-occurring mutations for accurate classification and risk stratification in these patients. It can also identify hereditary cancer risk via MMR testing. If you see that the biopsy reports and post-surgical TH specimens, they have shown that the diagnostic concordance between the endometrial curettings and TH VSO specimens is very high. It also helps in guiding proper treatment, because TP53 mutated endometrial cancers require intensification of therapy, whereas polymutant endometrial cancers requires no adjuvant therapy. We follow de-escalation in these patients. Last but not the least, one should keep in mind the cost and accessibility of this assay to the patients. Should be aware of the small proportion of endometrial cancers harboring more than one molecular classifying feature, termed as multi-classifiers. If one was to strictly follow the proposed diagnostic algorithm, it would be difficult to identify this unique cohort of tumors. So next generation sequencing is likely the most efficient and effective method to identify these patients, and it has the ability to find more of these cases compared to your conventional techniques. So the current consensus is that in tumors with a pathogenic mutation of the poly gene, this mutation takes precedence over all other abnormalities, and such tumor should be classified as polymutant endometrial cancers. If the patient is not affordable, you better begin with polymutated status, like to advise the patient to undergo polymutation testing by sequencing. Thank you for your attention. Acknowledgements to my team.